board meeting for Access Health Connecticut. I will start by asking you to take attendance. This is Charlie Klippel, Chair.
Just before we start, Mr. Chair, I just want to say that this meeting is being recorded for the minute-taking purposes, as well as for posting the recording of the proceedings on the AJZ's website. Roll call for attendance. Charles Klippel.
Here, thank you.
Paul Philpott.
Here.
Cece Woods.
Here.
Thomas McNeil.
Here.
Grant Ritter. Dietrich Gifford.
Present.
Thank you. Steven Hernandez. Matthew Bratman.
Here. Steve Hernandez here.
Thank you. Andrea Barton-Reeves, Commissioner of DSS.
Here.
Claudia Gaultier on behalf of Secretary Jeffrey Beckham, OPM.
Here.
Thank you. Theodore Doolittle, OHA.
Here.
Carlene Zambetti on behalf of Commissioner Nancy Navarrete from DEMIS.
Here.
Thank you. Paul Lombardo on behalf of Commissioner Andrew Mays. Sid.
Here.
Thank you. Commissioner Manisha Tutani at DPH. Thank you.
Martian, thank you very much. And if we could ask the officers of the company to also introduce themselves, starting with James.
Thank you, Mr. Chairman. Good morning. I'm James Michelle, the Chief Executive Officer for Access Health Connecticut.
Gina Walsh, Director of Operations, Access Health Connecticut.
Good morning, Daryl Jones, Director of Finance, Access Health Connecticut.
Hi, good morning. Rebecca McClear, Director of Technical Operations and Analytics, Access Health Connecticut.
Good morning. Susan Rich-By, Director of Legal and Governmental Affairs, Access Health Connecticut.
Good morning. Caroline Lee Ruette, Director of Marketing, Access Health Connecticut.
Good morning. John Carbone, Director of Small Group and Product Development, Access Health Connecticut.
Good morning, everyone. Glenn Jurgen, Director of Human Resources, Access Health Connecticut.
Good morning. Tammy Hendricks, Director of Health Equity and Outreach, Access Health Connecticut.
Good morning. Janelle Maloney, IT Director for Access Health Connecticut.
Mr. Chairman, this concludes us. Thank you.
Thank you very much. I appreciate it. Martian, I understand that there are no public comments. Is that correct?
That is correct, Mr. Chair.
That's good. Then we'll move on. If I could have a discussion, if any, on the minutes of the last meeting. Are there any comments or corrections to those minutes? If not, I'd ask a motion to approve the minutes from the last meeting.
So moved. C. Woods. Yeah. All right.
Okay.
Ms. Woods.
Okay.
Thank you. And I think I heard Tom maybe a second.
Yes.
Terrific. So if we could have a vote on the minutes, Charlie Klippel, yes.
Paul Philpott.
Yes.
Claudia Gaultieri.
Yes.
Dietrich Gifford.
Yes.
Grant Ritter.
Yes.
Steven Hernandez.
Yes.
Andrea Barton-Reeves. Commissioner Reeves.
Yes.
Thank you. Theodore Doolittle.
Yes.
Cece Woods.
Yes.
Thomas McNeil.
Yes.
And Matthew Bratman.
Yes.
Thank you.
Thanks very much. We are going to make one change in the in a committee assignment, and that is to replace Dr. Gifford with Andrea Barton-Reeves, and as part of the Finance Committee. If there any discussion of that change?
I gladly cede my spot to the new DSS commissioner and wish her all the best.
Thank you.
And we thank you for your service on this committee. So you've set the bar high for her to match. Thank you.
Well, let the record show that Mike Gilbert and Nick Vendetto very ably represented DSS on that committee. So I thank them for their service as well.
Terrific, terrific. Thank you very much. Hearing no further discussion, I would ask for a motion to make this substitution on the Finance Committee.
So moved, Gifford.
Thank you.
I second it, Tom McNeil.
Thank you, Tom. Charlie Klippel, yes.
Thank you. Paul Philpott,
Yes.
Claudio Gualtieri,
Yes.
Dr. Deidre Gifford,
Yes.
Grant Ritter,
Yes.
Steven Hernandez,
Yes.
Andrea Barton Reeves,
Yes.
Theodore Doolittle,
Yes.
Cece Woods,
Yes.
Thomas McNeil,
Yes.
and Matthew Brackman.
Yes.
Thank you.
Thanks very much. So, James, the floor is yours, please.
Thank you very much, Mr. Chair. Once again, good morning all. I'm James Michelle, the Chief Executive Officer for Access Health Connecticut, and thank you for joining us this morning. Let me start with a few items before we get into the meat of the agenda. Last month's meeting, certain board members we received some questions regarding open enrollment during the January board meeting. Rebecca McClare, Director of Technical Operations and Analytics, will address those questions during her open enrollment report. Another item that I want to mention to the board is the Health Plan Benefit and Qualification Advisory Committee is hard at work on the plan and the plan requirements for plan year 2024. We may need to schedule a special board meeting in March to approve their recommendations. We'll keep you posted on that meeting date. As a reminder, next Friday, February 24th, we will have our fourth board training meeting. This meeting and fourth and final board training meeting, and this meeting will be dedicated to how Access Health develop its budget each year, and that's again next Friday, February 24th from 10 to 11. And finally, I wanted to share that the 2022 annual report will be mailed out within the next week to the board members. The theme for this year's report is Health is the Heart of the Community. So this is the cover of our annual report, and every one of you will get this in your mail within the next week or two. Regarding our meeting today, we will begin with a 2023 final open enrollment update from Rebecca McClare. Following that, Rebecca will join Caroline Lee Rouette, Director of Marketing, and Tammy Hendricks, Director of Health Equity and Outreach. We will review the Medicaid unwinding preparation for enrollment projections, marketing, and outreach as Medicaid unwind. A couple of items on that. We have been working very closely with the Department of Social Services, the Office of Health Strategies, and the Office of Policy and Management over the past year in preparation for the Medicaid unwinding, which is scheduled to start on April 1st. We have created a 12-month strategy with the goal of minimizing gaps in coverage for Connecticut residents who are currently in part of that cohort of 430,000 or so Connecticut residents. Some members of the Access Health Connecticut leadership team recently participated in 2 public forums with the Connecticut General Assembly, including the Insurance and Real Estate and Human Services committees. Access Health and DSS discussed the Medicaid unwinding plan and also the end of the public health emergency. The plan was well received. However, there were some follow-up questions that we are currently working on. We will continue to meet with all stakeholders, and we'll need funding from our reserves to support the additional marketing and outreach work that we will have to do in support of the 12-month unwinding of Medicaid over the next 12 months or so. Following that, Tammy Hendricks will give an update on the Broker Academy. About a week ago, we announced the second year of the Broker Academy, and applications for the program will be available beginning February 27th. And if we have time, Susan Richby, Director of Legal and Government Affairs, will conclude the meeting with a legal and policy update on the Affordable Care Act and its impact to Connecticut residents. Thank you, and we will, for your continued support. I would pause now for any questions.
Dr. Gifford.
Thank you. What was the intention to discuss the budget today? Is that on the agenda in terms of the request to use reserves for that purpose?
No, it's not. We're still working out the numbers, see where we what our needs are going to be. Then
Okay.
we'll go back to the finance committee April at its April meeting, and then go to the board then.
Okay, so just to say that we at OHS also have some additional funds around outreach for the unwinding, in addition to the funds that have already been allocated to DSS for this purpose. So I just want to make sure that we have a comprehensive picture across DSS, OHS, and Access Health of the funding that's already been allocated to this purpose. And I'm not positive that we've done that yet. So we can obviously take this offline, but I just want to get that on the table, that there is some additional funding at OHS for this purpose. It's related to Covered Connecticut, but also the unwinding.
Thank you, Dr. Gifford. Well, I think we presented a comprehensive plan and strategy and proposed budget, but the budget was not finalized the last time we spoke. And we are working on that. That's why we're not ready now to bring anything to the board. So we hope by April, we'll have final numbers. And at that point, we'll go back to the board to take money from reserves to support Access Health portion and to support this effort.
Okay. Well, I don't want to speak for Claudio, but I will volunteer he and I to make sure that we've got that comprehensive picture for you. Thank you.
Thank you.
That's terrific. No, sorry, go ahead, Claudio.
No, I was going to say, yes, I think that's a welcome invitation. I'm happy to be part of that. I think also we need to be mindful of the fact that there's a little bit of a timing issue that we may need to figure out and finesse, meaning that our new budget doesn't take effect until July 1. It probably won't pass until June. We put, at least the governor has recommended, significant other supports to wrap around, including those with chronic conditions, cancer treatments, for example, to have additional navigator supports. Those won't materialize until June. I think we can manage a little bit if we are staging the rollout of redetermination in a way where we're starting with the very lowest income first. It probably won't be as big of a problem until after July, but it may be helpful to wrap around Access Health's resources to create a bridge until such time as we get whatever the legislature agrees with us needs to be augmented in this budget that's coming up.
Thank you. It's a major event, and it's one that will require coordination all across the country, but certainly coordination within Connecticut. And so it's terrific to see this conversation. And James, when you present the budget for Access Health, let's make sure it includes the references to the other money that may be available. Matthew Brockman, please.
I'm good, thanks.
Okay, all right, fantastic. I'm gonna just put a quick pitch in for the board training on the 24th. Probably won't have that piece of the budget quite done, but those are very valuable sessions. If you have not attended one of those budget trainings or one of those trainings, Daryl does a terrific job, and I recommend you join if you can on the 24th. Thank you. All right, James, so to your agenda, and let's begin with the open enrollment numbers.
Thank you. Rebecca McClare is going to walk us through the presentation. Rebecca?
Good morning, James. Thank you. As James said, Rebecca McClare, Director of Technical Operations and Analytics here at Access Health Connecticut. Since our last board meeting, our team has been reviewing the open enrollment data and preparing our annual report that has been posted to the website. and it will be shared, if not already, with the board via email for your review, so you can see some more details. Today, I'll just be focusing on a few highlights from that report, but obviously there is a lot more information in that full and comprehensive report. For those of you familiar with last year's reports or prior year's reports, we did add some pieces of some impacts from the Covered Connecticut program now that it's been fully implemented, as well as some numbers around our standalone dental plan integration with our enrollment system. So with that, if we can go to the next slide, we'll take a look at some highlights of the information. So this slide shows the trends over the past 3 open enrollments from our open enrollment 8, 9, and 10. So I'm not going to get into the details, but we will see that due to the Medicaid extension being in effect over these open enrollment periods, we do continue to see the number of Husky determinations increase to over 900,000 individuals at the end of this open enrollment session, which according to our record is an all-time high for the 10 years of our Access Health recording. So that is something that we just want to point out, because that does impact potentially the number of QHP enrollees, folks that normally would have transitioned from a Husky program to the QHP. In addition, we can see another item that I wanted to point out is the third row down there, the percentage of the population, QHP population with financial assistance. We do see a significant increase in that between open enrollments 8 and 9, directly as a result of the increased financial assistance made available by the American Rescue Plan. In addition, we see that number continue to grow, although slightly, between open enrollments 9 and 10 due to the Inflation Reduction Act, which allowed provided the increased financial assistance to continue through plan year 2025. So we do see our enrollees continue to be able to take advantage of that increased financial assistance. On the right of the slide, we did pull out some of the main points of the Covered Connecticut population. So they are included in the overall numbers in that third column, the open enrollment 10 numbers, but we did just want to pull those specifically out for that particular population so that folks could get a feeling of where that is. So as a reminder, at the end of open enrollment, we did have 15,411 individuals enrolled in the Covered Connecticut program. That's 14% of the overall QHP enrollment. So again, a great turnout there, and the opportunity for those folks to take advantage of the additional benefits is great. We also see that on average, the age of the individuals enrolled in that Covered Connecticut program is about 5.5 years younger than the overall enrolled population. We are continuing to monitor that, however. The one last thing to note on this slide before, sorry, Marcia, I lost my notes. Can go back up. I just did want to note that the auto renewal rate for the Covered Connecticut population is with 89%. I mean, 89% of those folks that had Covered Connecticut last year were automatically re-enrolled into the Covered Connecticut program this year. That's higher than the overall average of our QHP enrollees. And that's significant for this group because that means they didn't have to take any action to retain their Covered Connecticut coverage. There was no chance for them to lose those benefits, especially since that population isn't receiving invoices from the carriers. There sometimes can be some confusion as far as with their coverage year over year, but having that auto enrollment rate be very significant is quite helpful to that population. Okay, let's continue down, Martin, to the next slide. This slide does contain quite a bit of information. Again, it is in our full deck, but I did want to share this and share a couple highlights. This slide provides a comparison of enrollment rates into the individual plans, comparing 2022 and 2023 at the end of open enrollment periods. So while we do see by that blue line, that right about in the middle of the screen, that's CBI Choice Silver Standard POS plan continues to have the largest number of enrollees. The Connecticut Insurance Company, Inc., or Chi-Chi Silver Plan did see 53% growth this year, as opposed to a 5% growth for the Connecticut Silver Plan and a 4% growth for the Anthem Silver Plan. So I wanted to point that percentage growth out because that's not as obvious as the overall, the numbers. I wanted to make sure Chi-Chi got that credit. Also to note, the Anthem Bronze HMO Blue Care Prime with added dental and vision, which is up at the top, the first bronze plan listed there, did see a 235% increase in enrollment year over year, which was the largest growth that we saw for any single plan. And that contributed to Anthem's continued market share growth. Overall this year, Anthem had increased their market share to 32% of our enrollment compared to 24% last year. So that, I believe that increase did contribute to that growth significantly. Next slide, Martin. This page on here talks about our integrated dental and standalone dental plans. We see that 83% of the approximately 9,000 enrollees in our dental plan this year selected an Anthem dental plan. Additional information on the overall dental population will be available in the full report. However, keep in mind that the majority of the dental enrollees are also enrolled in our medical plans through Access Health, and therefore the demographic profiles are quite similar. Just to remind folks that prior to this year, consumers interested in enrolling in dental coverage through the exchange did need to access a separate system. That meant they needed separate credentials, a different username, password, all of that. They had to also re-enter all their household information before purchasing or shopping for and purchasing a dental plan. In addition, only Anthem offered dental plans on the exchange last year. This year, we've integrated the dental into the existing shopping experience, and we added a new carrier. Connecticut Insurance Company, Inc., or Chi-Chi, is also offering dental plans through the exchange this year. So it's easier than ever for our enrollees to purchase dental coverage through the exchange. Overall, our dental enrollment did increase by 66% since the end of open enrollment last year. So we're, again, the work that we've done is proving out, and we're quite happy to see that increase in enrollment. Next slide. As James mentioned, we did have some questions during last month's board meeting, so I did want to address those here. If there are follow-up questions, I'll pause at the end of each one to make sure we've addressed the concerns and the questions adequately. So first, we're going to talk about the question from Ted Doolittle regarding the increase in health insurance enrollments across the nation, mostly on the FFMs, and looking to see why the state-based marketplaces enrollment is down. So a few things when we were looking into this, we believe that both the Medicaid expansion to increase the FPL limits for Medicaid eligibility, as well as the Medicaid, the continuous coverage provision, or the Medicaid extension, are large contributors to this discrepancy. Those see that Connecticut Medicaid enrollment in particular is up 134% since 2019. That's quite significant. If we look back to the beginning of the exchange 10 years ago, the Medicaid enrollment has increased over 600%. So a lot of those individuals that are able to take advantage of that expanded Medicaid coverage or the eligibility in Connecticut or in the other SBMs, that does not occur for all the FFM states. So those individuals are able to enroll into a QHP plan with the additional financial assistance. And so we're not seeing that increase in that population on the SBMs. Also, since the Medicaid extension came into effect. Individuals who normally would have transitioned off a Medicaid program onto a QHP plan are remaining on their QHP plan. So that's causing or resulting in less folks being able to enroll in a QHP. So I think traditionally, based on our information currently in our system, about 15% of the folks on the Medicaid extension may have qualified to enroll in a QHP plan based on the information they reported at the time over the last 2 years. So those numbers would directly affect at least the Connecticut, the Access Health numbers for a QHP. In addition, another factor which may have impacted QHP enrollment for those SBMs may be the fact that the overall average premium for the benchmark plans for those SBM exchanges increased by 5.4% as opposed to only 3.4% for FFM states. So that, for some folks, that can be a factor. If the rate increase was too much, they may have chosen alternate insurance options. And for reference, we did also include a chart that we pulled together that shows the acquisition or new consumer rate and the retention or returning consumer rates for the various types of marketplaces. And you can see Access Health is right in line with the other SBMs, and the marketplaces for retention are a little bit lower, but our acquisition rate is quite a bit better than the overall SBM average. Question?
Rebecca, let me stop you there and ask, since this is a question asked by Ted, whether Ted has any follow-up questions.
I appreciate the work on this. I'm going to be digesting it. No comments right now, Charlie, though. Thank you so much for the work in addressing the question, though.
Okay, thank you. And as with any of them, if there are follow-up questions, reach out and we will provide clarification as possible. All right, continuing to our next question from Claudio Galtieri. For the covered, and this is specific on the covered Connecticut population, we're looking to see how many are completely new enrollees, never had health care, versus those who are already on the exchange, but able to get additional covered CT benefits. So again, I just want to clarify when we're talking never had health care, it's a little bit tricky for Access Health to really identify that. So our definition of retention and acquisition, or what we can track, is if they had coverage through the exchange, whether that was on a QHP plan or Medicaid. So we've broken those down into 3 buckets. One is, did they have QHP coverage or Medicaid through the exchange in 2022? Or did they have coverage through us at some point prior to 2022, but not in 2022? And then also, did they not have coverage through us at all? So those were the 3 basic buckets and that are outlined in that chart on the right. And overall, 96% of our covered Connecticut enrollees for 2023 had coverage, either Medicaid or QHP coverage, at some point in 2022. So the majority of them retained that covered Connecticut coverage. Whereas there was a small portion, 146, didn't have coverage through Access Health in 2022, but they did at some point before that. So they maybe had employer coverage and came back onto the exchange. Or while we did acquire 412 new individuals, we had completely new to the exchange, and were able to take advantage of the covered Connecticut benefits. So hopefully, now Claudia, if there's additional questions there.
Yeah, I think that this would be a great benchmark to have at some point when we're sort of through the unwinding, or maybe midway through the unwinding. I suspect, if our theory of the case is right, that it's going to be the soft glide path for those that are redetermined ineligible for Medicaid. I suspect that bucket will go up a lot, so it would be helpful. I think you've defined the categories as I'd wanted to see them. And I think the next inflection point is how the public health unwinding changes some of this. So it's a great snapshot now. if you're amenable to it, I'd love to see another 1 or 2 snapshots through the unwinding.
Certainly. Thank you.
To Claudio, that's something we could do on a monthly basis for the board.
Oh, that's
maybe,
terrific. I didn't want to put that much pressure on you guys, but yeah, if that's
No.
easy enough, that's a great,
Yeah.
we would actually be able to see some trends.
So, and again, we could send it out to the board on a monthly basis, but we could report on it maybe on a quarterly basis, so that we don't have the board every board meeting. All right. So we'll send out a monthly report to the board, specifically outlining the schematic that we've created here. Then maybe every quarter we'll report to the board on a quarterly basis as to just do the comparative analysis and
That's
what,
excellent.
when, where, and how. Okay.
Thank you.
Thank you. Okay, and another question from Claudio related to this. This is actually something we talk about internally quite often. It's the number of enrollees in a bronze plan who could qualify for silver cost sharing, but opted not to enroll in a silver plan, and focusing on those under the 250% FPL. So overall, about 5,000 individuals are enrolled in either a bronze or gold plan that qualify for CSR. That's about 13% of the overall number of individuals that are eligible for CSR. So by the vast majority of those eligible for the CSR benefits enroll in a silver plan and take advantage of those benefits. So we are that, while yes, that 5,000 individuals is a significant number, overall it's a smaller percent. And of that population, of those 5,000, about almost 2/3 of those are under the 250% FPL mark. So again, a good number of them do fall within that range. So these consumers are presented during the enrollment process. They are presented with a warning message in the application advising them that they might be, by continuing to select a non-silver plan, they may be missing out on some benefits. In the next slide, we do have that messaging for you. Thank you. So I'm hopefully you can read that slide. If not, make it a little bit bigger. But that box on the right with the gray, basically, if someone, again, they're eligible for those CSR benefits, they're selecting to purchase or enroll in a bronze or a gold plan or non-silver plan. The message basically, and I'll read it out for folks, they're eligible for cost sharing reduction plan that could lower the amount you would pay when you get services under your plan with a provider such as doctor or pharmacy. This is only available if you purchase a silver plan. And then, for example, the plan's in-network deductible is X dollars for an enrollee. However, the deductible, if you choose a silver plan, could be as low as Y dollars. Please refer to the plan documents for coverage information, as the deductible may differ for some services. At that time, they're allowed to either continue with the purchase of that plan, or no, they want to select a different plan. If they choose to select a different plan, they click that button, they return back to the shopping page, and they can change their plan to a silver.
Rebecca, Dr. Gifford has a question for you.
Thanks, Rebecca. And Claudio, I think this was a really good question. I just wanted to suggest that this population, these 5,000 people in particular, be a focus of our outreach efforts going forward. Because this language, I understand, I understand and applaud the fact that we do this warning, but being a person who enrolls my elderly parent in a Medicare Advantage plan every year, I can tell you that the exhaustion level and the lack of comprehension is very, I mean, you guys know this better than me. It's very significant. It's very challenging to understand these things sometimes. And so I would suggest, because these people may in fact be paying a lot more out of pocket than they need to, that we think about focusing on this group with a plain language outreach campaign that is very clear that they may be able to save money. And I don't know if we have them call us or direct them to come in. But that I really think Claudio hit on something with asking that question, and that maybe we should consider a specific effort for this group.
I think it's a very good comment, particularly since our fastest growing plan seemed to be a bronze plan. So it feels like there's work to do.
Dr. Gifford, thank you for that suggestion. We'll put together a strategy and go back to the strategy committee and this board. And it'll be a communication outreach strategy with this population. Just do a direct outreach. Say, hey, you leave money on the table. Do you want to make adjustments to your selection? We think, to your point, this is, going through our application is very tedious. It takes a long time. By the time you get to the screen, and you may bypass it, although as clear as it may be, and people may not read it, but doing a direct outreach to the population might be an extra level of effort that might save people money. So we'll look into that and come back to the board with our suggestion.
Thank you, James.
Welcome.
Ted Doolittle has a question for us, yes, as well.
Yeah, thanks, Mr. Chairman. Ted Doolittle, Office of the Healthcare Advocate. So first, I do want to, applaud the call out box here, and that's a good progress to have that in place. And we've worked on this for a few years, but I agree wholeheartedly that 5,500 is a pretty big number. And I guess I would want us to make sure we've surveyed the other high-performing state exchanges in terms of any strategies that they're using. Perhaps there are some lessons learned out there. I think we're probably, doing a relatively good job on this. It wouldn't surprise me at all to know that this call-out box alone puts us in the vanguard, but it's obviously not enough. So first, applaud the focus we've had on this so far, but again, seconding Dr. Gifford's recommendation to dig in and do more.
Thank you.
Thank you.
Okay, we ready to transition? Any
Rebecca?
other questions before we move on to the next topic, James?
No, we're good.
Sorry,
Cody, I just hope this addresses your concern. I know we have to do a little bit more work, a little bit more digging into this. Well, extended work a little bit more. We'll come back to the board and as to the notice we're going to send out to this 5,000 and to encourage them to take another look at their decision. But we hope this at least addresses your question for the moment rather.
Yeah, I think that this is exactly what was intended, to spark a look at what's happening and how can we make it more effective, our outreach, and make sure that people are fully leveraging the federal subsidy. So I think this is fantastic. You've sparked some real actionable next steps, and look forward to working with you, James.
Thank you. And Ted, to your point, Ted, when we first created this box was discussions with the board 3 or 4 years ago. And the board was concerned about people leaving money on the table. So that sparked us to create this in this edition. And back then, Ted, we did look at other states, see what they were doing. I believe at the time, no one was doing anything. And but we'll go back and taking a look at it, see if anyone is taking any steps and to see if they're doing anything better than we are doing. And we're very happy to still any ideas and thoughts that they are doing, and that's going to help us continue to have lower costs for our customers.
Thanks, James. Before we move on, Susan Richby has a comment or a question.
Oh, thank you, Charlie. I just want to make sure everyone understands at this point, like we wouldn't be sending them a notice now for 2023 because they don't have a special enrollment to change plans. You know, they wouldn't qualify to change plans right now, but as James mentioned, this would be our planning strategy for next open enrollment period. Thank you.
Thank you.
Mr. Clipple, if I can make just one final
Sure,
comment.
absolutely. Okay.
I do wonder in terms of when next year rolls around for this 5,500, would there be any way to give them a side-by-side comparison of what they paid in 2023 versus what they could have paid had they moved to a silver plan, and give them a quite personal view on how much money they left on the table? I don't know whether that's logistically possible, but certainly would be powerful if it could be done.
Ted, I think the only thing we do, Ted, we could look at the premiums. That's about it. But in terms of copay, deductible savings that they could have had, we don't have that level of detailed information on an individual basis for our customers. And that information is with the carriers, not with us.
Yeah, no, I understand that, and maybe we can talk to them and see if they have any ideas on how to, make sure that people get as hit between the eyes as we possibly can on this.
Okay. We will explore that with the carriers.
And just to, I think Rebecca mentioned this, the largest percentage of this group is the people who are only eligible for the 73% CSR. And there really isn't that much difference between the 73% and our standard silver, which we always have at the top of the range. So our standard silver, as Rebecca has here on the slide, has an AV of 72%. And the CSR plan that this large group of about 3,500 people is eligible for is a 73% CSR plan. So it's not that different. The biggest difference is when you get up to the 87 and obviously the 94.
Super helpful discussion. Thank you, Rebecca, for leading it. If there are no further questions, I'm going to ask you to shift gears and talk about the unwinding.
Okay. Martin, you want to? Okay. So as James mentioned, we're going to start off our Medicaid unwinding discussion. I'm going to give a little overview of how where we are in our planning. We have worked with DSS and OHS over the last year plus on this plan. So now we have the guidance. So we are starting the process of turning things on and enacting our planning. So since the Medicaid extension will be ending on March 31st, DSS worked on a 12-month plan to redetermine that population. So based on data from last month, this about the end of last month, that's about 430,000 individuals are currently enrolled in a Medicaid program under this Medicaid extension. So you see that's the fourth column here is at the bottom there is our total as of the end of January. So DSS has decided to, for lack of a better term, to stagger the redeterminations of this population over the next 12 months. And they're starting with the households who have gone the longest without a redetermination. So those households that have been have the oldest original coverage end date from March 2020, those that were to come off of their Medicaid program in March of 2020 and April, those will be the first that we're going to process through the redetermination. So it's kind of an accounting, digging an old accounting term, first in, first out, and we'll stagger the spread the volume.
Rebecca, could I stop you for just a moment? Sure. Because Dr. Jutani may have a question, and I don't want to get too far into your presentation without letting her ask it.
Thank you.
Sorry, thank you for that. I'm sorry to interrupt. I just wanted to confirm, make sure I understand this. So the 434,000, that is only people with the extension? Is that correct?
Correct.
Okay. And maybe for just for my knowledge, and I apologize that I don't know this offhand, but for Commissioner Reeves or Dr. Gifford, the total Medicaid population is how large? Does
It was
any,
about,
like,
I believe it was about 930.
922.
Almost a million,
920.
yeah.
Yeah.
Yeah, 920,000 and change.
It's close to, that's right. It's about 920, 925.
okay. All right, so about a third of our, I mean, a little bit less than a third of our population in Connecticut.
That's
I
right.
mean,
That's correct.
that's like actually quite staggering to think of it that way. Okay, but
Yeah.
okay, so this is just the extension. Thank you. Thank you for clarifying that.
Yeah, sorry about that. Yeah, I did want to focus the numbers down to just that extension population, but thank you for bringing that up because the normal course of business, right? The monthly Medicaid redetermination process, that's going to continue. And what we're doing is the reason this 430,000 extension population is being spread across is it's being rolled into that existing monthly redetermination or renewal process, right? So that portion of that population will continue on their normal schedule. They're taking these 20 to 30,000 additional people each month and processing them. So that's, obviously we don't want to process everyone for various reasons. We don't want to process everyone right in April. That would just bog tons of systems down and impact lots. So that's being spread across the 12-month period. So if you see some reports on how many were actually processed in any given month, it will be higher than these numbers, but that's because it includes the regular Medicaid renewals and this extension population.
Thank you very much.
And again, the decision from DSS on the way to spread this population out was to start with those that were on the extension from spring of 2020, and then the newer, we have continued processing down throughout the year.
And Rebecca, Ted Doolittle also has a question.
Yeah, thanks. Thanks for this information, and I don't mean to take you off of your flow here, but in terms of the column of total projection volume, I was kind of expecting that it would be kind of similar month to month, but it does bounce around. Why isn't that redetermination population, divided up into 12 equal tranches?
Great question, Ted. So what we don't have on this slide, but we can certainly provide it for you. In any given month, right, the volume is different for various reasons. Folks that are enrolled in Medicaid and coming up for renewal. So what we tried to do is look at that population, this 430,000, this extension population. The DSS group took them by that month when they were supposed to initially end their Medicaid coverage. And there's kind of a processing cap from a volume standpoint that they were trying to achieve. So it was a math numbers game of making sure that the anticipated regular population plus a portion of the volume based on when they were going to end. We tried to keep them whole months. So everyone from March of 2020 is together. We didn't spread that across months. And then tried to balance that out so that when you look at the combination of both the regular and the extension population, that overall population that's being processed each month is more consistent. I just remember you're looking at half and a portion of that overall population. And I'm not getting too deep in I wasn't involved with the discussions from a technical standpoint, but there is a limit from a performance standpoint that they were trying to achieve. I would probably defer to the DSS folks for more information on that decision. But it is fluctuating month to month, but it's the factors that went in, the main one being the volume that was going to be processed in any given month.
So there, the two biggest components to this. Number one is the people who would regularly annually renewed for Medicaid. That's one. The other part is the population that has been part of the extension. those are the two biggest part of the end, that changes from month to month, depending on the enrollment numbers, depending on when people enrolled in Medicaid. I hope that provides some clarity as to why the numbers are not. And then we try our best to try to balance it off on a month-to-month basis so that we don't overwhelm our system, our call center, and our other vendors. I hope that was
Well,
helpful.
that's helpful. I see we've got a couple of challenging months in there with the 54,000 one month and 56 others. So hopefully we'll be able to manage those bumps well.
Yeah, the good thing about this, I know Rebecca's gonna get to this in the next column. Majority of this population will not have to do anything, but they will be automatically renewed and back into Medicare. So Rebecca, why don't you go into the next column?
Yeah. Yeah. So two things following up on that, exactly, James. The next column, based on the projections and the analysis that DSS has done, the expectation is about 75% of the individuals processed through the monthly redetermination renewal process will be automatically renewed into and enrolled into a Medicaid program. So there have been some improvements over the last year there to improve that rate of automatic renewal. And I think DSS has presented that in other forums, and we can certainly probably share that information. So that's that next column, remain eligible for Medicaid or TMA. Those folks will be, again, automatically processed and re-enrolled into that program without any intervention by the individual. So that's the good news. About 75% are anticipated to fall into that bucket. One thing to know, I just want to comment on the concerns related to those spikes in volume. These improvements that have happened from a system standpoint, when they've done their projections and their analysis, they've compared the rates that fall out or those that would need to come back in and manually take action to renew. And those volumes are actually similar month by month to what we had 2019 and earlier, before the PHE. So they're optimistic, DSS is optimistic that those volumes of folks that are going to need to come back in and take action and maybe make a phone call or get some assistance is similar to what we've seen in the past. So the improvements in the system to ensure this automatic redetermination and re-enrollment into a Medicaid program when eligible, those improvements are really crucial for this process. So again, they're anticipating 75% will not need to take any action. Those remaining individuals, which are those last two columns, where those are folks that are, will need to come back into the system to take action, to review their application. They could have been rejected or failed their renewal for Medicaid for a number of reasons. It could have been the income in our system now no longer qualifies them for a Medicaid program. It could be something else altogether. But looking just at what's in the system currently, we're looking at a split of about 1/3 of those folks may qualify to enroll in a covered Connecticut program. So again, there's lots of caveats here, but because it is based on what's in the system today. If someone hasn't come in and updated their income in 2 years, and then they come back in and they change their income, they may now no longer qualify for covered CT. They may qualify for a QHP with APTC. They may qualify for Medicaid. So we can only kind of forecast or project that breakout based on what we know. What we have available to us. Any additional questions on this? I know it's a lot to digest, and we can certainly provide some follow-up answers for you. I'll turn it over to my colleagues to continue the Medicaid unwinding discussion. Thank you.
Thank you, Rebecca. Caroline Lee Rouette here, Director of Marketing at Access Health CT. So we're going to talk about Medicaid unwinding, again, here from the perspective of marketing. And we want to start with our existing efforts. To date, the Department of Social Services has a wonderful campaign in market. This is scheduled to conclude before unwinding begins. And the theme is Update Us So We Can Update You. This is particularly important, as we all know, because folks have not needed to come in and update their information over the last several years. So as unwinding continues, we need to be able to do direct-to-consumer outreach, and so does the Department of Social Services, right? So we can tell people about the changes to their coverage and what they need to do. So what we're doing at Access Health CT is really amplifying this campaign right now through our owned channels. So we are amplifying this on our social media, as well as email updates that we're sending to consumers, our community partners, many of which are those that the DSS folks work with as well. Some are different, so we're really amplifying that beyond their reach. We're also reaching out to brokers and CACs, these people that are going to be in the trenches helping folks, right, with the unwinding process to make sure that they know about it as well. Additionally, we've made some really great efforts working collaboratively over the last several months, and we will continue to do the same moving forward, is providing review and input, and in some cases even co-branding some notices that are going to be sent to Connecticut residents impacted by the Medicaid extension and unwinding. Because as we all know, they're going to have to come to the Access Health CT website or in some capacity work with us in order to either be redetermined back into Medicaid or another option, maybe being a Covered Connecticut program or a qualified health plan if they are so eligible. Next slide, please, Martin. And as previously mentioned by James, we are working to secure funding. We're working with the Department of Social Services, the Office of Health Strategy, as well as the Office of Policy and Management on a potential 12-month targeted advertising campaign. What this would include is statewide coverage, but a concentration on communities that have high populations of residents impacted by the Medicaid extension, right? We've got great data. We know where these people are, having been around even for 10 years. We've got our own data to work with as well. And so we can really be smart with our money and make sure that we're in the communities where we need to be. Right now, we are expecting this to launch in May, but we will keep you posted on more timing as this develops. Another important note here, folks, and my colleague Tammy Hendricks, the Director of Health Equity and Outreach, will follow my presentation here with her plans, but it's important to note that the marketing campaign, this paid campaign, is going to follow the outreach plan of targeting those certain communities by town and even at a zip code level. So Tammy and I are working hand in hand and sharing this data. We're pulling from the same information because we have our integrated eligibility system, right? We can pull that information out and make sure that we're working hand in hand. Like I mentioned, we are currently working to secure funding. That said, we have started the creative brief for messaging development. In order to have assets ready in time, folks, for May, we need to get going now. So as we work to secure funding, we are developing messaging that has just kicked off. So I don't have any preliminary news to share with you on what that is. But what we're targeting, depending on how much funding we can secure, are to share this message across several different platforms. None of these are guaranteed yet until we have that funding, but what we're looking to do is make sure this messaging is shared on TV, including broadcast and streaming if possible, radio, terrestrial, your traditional AM, FM, as well as some streaming options. We're looking at a lot of different out-of-home options, traditional billboards and posters, as well as transit options. So things like bus shelters, trains, and all of that. Looking at our community newspapers, making sure we're prioritizing those by minority newspapers. Social media will be significantly helpful here. That's something where we can target a lot using both our organic and paid channels. And then lastly, a plethora of different types of digital advertising, from advertising within search engines to the margins of certain websites and at a zip code level too. So much more to come on this because we do need to secure that funding, but we are actively working to get this stood up by springtime. And I'll pause there for any questions.
Matthew Brockman has a question.
Sure.
A quick question. Have we talked to, and maybe I missed it, the carriers about any efforts they may be thinking about in this space too?
Matthew, we have meetings scheduled with both carriers. As a matter of fact, we're meeting with Anthem tomorrow Again, it's a briefing about Medicaid unwinding, where we are and so forth. So all hands on deck. And we are scheduling a meeting with Connecticut as well. And the meetings are scheduled at 2 levels, at the executive level, also at the operational level. And talking with the carriers, sometimes we understand that when we talk with the executive level, sometimes it doesn't filter down to the staff level. So we have people connecting. I'm connecting with the CEO and this SLT. That's tomorrow. But we have another meeting scheduled with the operational folks, our operational folks, and there's to talk with the same information going to them as well.
Yeah, I'm just thinking from the marketing perspective, they've got some skin in the game too, right? So
yes.
I wonder if maybe there'd be an opportunity for them to help out with some of this work.
Yeah, we do collaborate with them doing open enrollment, and we share everything we're doing. We share with them, and so I don't know if you want to say anything more about this, Caroline, about the collaboration
we
we do with the
definitely
carriers.
share our messaging. We share everything so that it is, a collaborative effort, and they can also help to amplify what we put together in a very similar way that we're working with the Department of Social Services right now in their campaigns.
I think Matthew's point is a good one, which is we should get them to spend some of their dollars too.
Right.
Yeah. Well, we've been trying that for a long time, and a lot of time. So Matt, we have broached the subject with them before, and we'll continue to follow that up. And if we hit mark, we'll come back to the board, let the board know where we are from that respect. But there's a lot of collaboration going on for messaging. Make sure that we are not overlapping each other or canceling each other out. So that's ongoing. But the money spent is for us that could really be helpful to us and to our customers.
Dr. Gifford has a question as well.
Thanks. So I'm thinking back to the slide we just looked at on the eligible population that we're trying to reach here. And it's not a huge, thank goodness, it's not a huge portion of, if you start the funnel with the 1 million that Commissioner Gittani was asking about, and then you get down to the 400,000 that we need to redetermine, and then you subtract the 300,000 plus that we think we'll either have transitional Medicaid or automatically be redetermined, we're down to a pretty small number of people in a pretty narrow income band who we're targeting here. So I'm just putting on the table, and maybe we can talk about this in the same meeting where we talk about the overall budget that the state has already put into reaching these people, whether this type of a very broad TV, radio, billboards, newspapers, social media is necessary to reach that very niche and target market, or whether we might not be more efficient and effective with a more targeted outreach approach. I don't know the answer to that question, not understanding, marketing and communications, but I do think, having seen what the potential budget for this would be, I do think it's worth a conversation about whether, we can almost identify those people by name. It's a pretty small slice of the pie, whether a more focused outreach might be the way to go.
And Dr. Gifford, you're absolutely correct. Most of the money we're going to spend is be very targeted in the communities by zip code. I think that again, the media buys, you could target exactly what TV shows you want to, and what time of day, and what communities that you want to advertise on. So obviously, go ahead, Caroline.
Yes, there are several different types of media that we have outlined here that we can target on a zip code level. Even things like TV and radio, Dr. Gifford, if we do the streaming platforms by zip code. So yes, we know a lot of these folks by name, where they live. And so this media effort supports that direct to consumer communication that I think you're talking about is so incredibly needed. And we couldn't agree with you more, which is why Tammy, following this presentation, will talk to you a little bit more about what that kind of in-person handholding will look like. The concern here and why we think mass media may be effective for us and may be necessary is because a lot of folks have not updated their information. And so if we rely solely on a direct-to-consumer strategy, we may be sending mail that speaks specifically to someone that does not reach them.
Yeah, totally agree on the mail piece. Yeah.
You know, and that is really what we have at our disposal to do really effective direct-to-consumer communication to everyone. I'd have to defer to DSS on exactly what information you require. I think there's some changes happening at the FCC level on what we're allowed to do, especially with cell phones and texting without opt-in, as a direct result of the fact that we know we can't reach everyone right now with the old information that we have. But at Access Health alone, we can only require an address when somebody signs up. Email, as well as phone numbers for texting, are completely optional. So we know we will not be able to reach our whole audience with email and texting, which is why direct mail is so incredibly important. But if somebody no longer lives there, and we know this audience is incredibly transient, we know that there's going to be huge misses in terms of reaching out directly to people, and there will be gaps unless we're able to get in front of people in another way. So ultimately, I think that you're right, Dr. Gifford. We've had a lot of conversations that, you know, the direct-to-consumer outreach is going to be the most effective, but is it the silver bullet to reach everyone? I don't know that that's the case.
Thank you.
Dr.
Sure.
Giftani, I think, may have had a question, but I'm not sure.
I think it was mostly answered. I mean, I think the bottom line is I just agreed with Dr. Gifford's comments. But I think it sounds like it's to supplement the direct communication that you're talking about. So you still will do the personal outreach. It's just that if you can't get those people, because I think what I struggle with is a lot of this mass media, I think people look at it and sometimes think it pertains to somebody else, not them. You know, that's meant for others. It doesn't belong to, you know, does not meant for me. That's my concern. So like, you know, that direct communication, like, you know, we mean you, you know, I think is also necessary.
I think we're all on the same page, and it should be noted that those direct messages are primarily going to be coming from the Department of Social Services. These are Medicaid customers, so they're going to be hearing from DSS. So they own a larger part of the actual notices and mail that are going to be going out, although we're collaborating with them right now. We're providing input, we're co-branding because folks will need to come to Access Health CT. So to some extent, it's important to have our logo on things too, because this is where they ultimately need to come in order to keep their coverage in whatever capacity they're eligible for. But Access Health CT also has a role in that outreach. And I think maybe it might be natural. I don't want to cut off the conversation, but I think it's important that we hear from Tammy on what Access Health is going to be doing, you know, from that outreach perspective, because to everybody's point here, the mass media marketing is a support to that direct to consumer that's going to come primarily from DSS, as well as the in-person activations that are going to be coming from Access Health CT as well.
On that note, let's move to that next presentation. I'm a little afraid we're going to lose Commissioner Barton-Reeves in a moment.
Thank you.
So give her the last bit of this if we could.
All right. Good morning, everyone. Tammy Hendricks, Director of Health Equity and Outreach at Access Health. Thank you for all the conversations so far. In-person outreach is our department's main goal. So in terms of the outreach for the unwind, we have a few areas of focus that we think will make the most impact. That includes holding consistent meetings for our community partners in person and virtually if they request that. We host various educational presentations for consumers. And then we also provide the in-person enrollment opportunities for consumers throughout the state. So our plan really begins with targeting specific locations. Outreach is very personal, it's hand-holding, it requires a lot of manpower. So we know that we have to pick something, pick a plan that's more targeted so we can reach people and connect with people directly, but in a meaningful way. So with the help of Rebecca and the data analytics team, we're able to break down the unwinding population by county, which New Haven takes the lead with the most individuals on the extension, followed by Hartford and Fairfield counties. So from there, we were able to focus on the towns and cities that had the highest numbers of users. And so even though these are the focus areas for our more targeted outreach, we still maintain a presence in other cities and towns as well. And as Caroline alluded to, the marketing efforts support the outreach efforts. So we're maintaining a presence throughout the state. And during a typical outreach year for us, we do outreach to all of these areas. And as Dr. Gifford alluded to, keep in mind, we're looking to reach a much smaller group of consumers based on past renewals that Rebecca went through earlier. Smaller, but still significant number of folks. So our outreach plans will stay very flexible in case we may need to pivot, revisit multiple areas based on needs or based on feedback from community partners. So I'll pause here if you have any questions about the targeted cities for the Medicaid Unwind outreach plan.
Mr. Klippel, just make sure I understand. So thanks, Tammy. These cities are ranked by the population within the county? Is that how they're lined up?
These cities have the most users, so 500 plus users in each of these cities listed under the counties.
Right, but for instance, look at Hartford County. Does Hartford's above New Britain? Does that mean Hartford has more of a target audience than New Britain?
No.
Okay.
The cities are not listed in order, but the counties are. So New Haven County has the most users on the, yes,
Thanks.
Sorry about that.
But Ted, we have data that tells us which cities within the county is impacted most. And that's how we deploy our resources for outreach.
Okay, I just noticed they weren't like alphabetical, so I was just wondering if there was any.
No, I pulled them.
How they're
Yeah, I pulled them from a data set, so they're not alphabetical and it's not in order based on users. Okay, we can move on to the next slide. Okay, so I wanted to briefly go through what we typically do for outreach because it's going to serve as the framework for our unwinding plan. So right now, our team works closely with over 1,800 community partners throughout the state. This includes community organizations, other state agencies, religious organizations, hospitals, really any organization that's interested in learning about health insurance through Access Health could be a partner for us. So I've listed just a few on this slide just to serve as an example of the organizations we've worked with closely over the years. So outreach consists of a variety of activities. First, we hold monthly healthy chat presentations for our consumers. That link is available on our website. And this is a high-level informational presentation specifically made for consumers to learn about Access Health and the plans that we offer. So we also get the opportunity here to address consumer questions and concerns during these calls. So it's a great learning experience for consumers and our team as well. In addition, organizations can request that we do presentations for their specific groups, and my team will happily accommodate those. Consumers really enjoy getting their questions answered by our team members in person. So these serve as great meetings for our consumers. Then we have quarterly regional planning meetings, which are held specifically for community partners, CACs, certified application counselors, and our brokers. Here we share more detailed updates during these meetings, and we also gather feedback from them as well. They're out in the field. We're also out in the field as well, so we learn a lot from each other. And during these regional planning meetings, we're prepping our partners, and we have been for the past year. Really, we knew this unwind was coming, just we didn't have an end date, but we were keeping them updated along the way, starting early last year. So we're going to continue to reach out to our current partners, even new partners, to go through our outreach plan for the unwind and figure out how we can partner with different organizations to help them reach consumers that they serve as well. So that includes maybe offering trainings to organizations that their staff can be trained to become certified application counselors. If they have the space, we can possibly have an enrollment specialist or brokers on site for them. It could be as simple as providing printed materials for them to distribute. So we work with each organization and we try to provide support based on their requests and what works for them. Next, we have our navigator partners. They help us with outreach, but also they provide in-person enrollment on-site year-round for consumers. And we also work closely, again, with CACs and brokers in the field, right? And CACs and brokers are accessible to consumers all year round. I've actually added a link to our community partners page that has a directory of all of our certified counselors, and our brokers that can provide that in-person enrollment assistance throughout the year. So consumers can use this link and find help near them if they want that in-person help outside of our other events. And I also wanted a quick note on that. I wanted to mention legally that only brokers can help consumers choose a plan. And so CACs can help a consumer throughout the enrollment process, explain the plan options. But if a consumer does not know which plan to choose, they have to be referred to a broker. And so that's state law. That's not an Access Health rule. And so this is where the Broker Academy will come into play for us. We currently have hundreds of certified brokers that we work with throughout the state, but the Broker Academy is training new brokers in these hard to reach underserved areas that are probably going to have the highest amount of users as well. So this is just an overview of what we typically do for outreach, and this will serve as the framework for our unwinding plan. I'll pause there for any questions. Okay, great.
Thank you.
Yeah. Okay, so this is our outreach plan for the unwinding. There's a lot going on this slide. So what we're going to do is ramp up activities that we talked about on the previous slide to reach as many consumers as we can. Again, we'll focus on the areas with the highest numbers of consumers on the extension, right? A lot of manpower will go into these areas, but then we'll have marketing on the top, kind of keeping us present in other cities as well. So we will be continue doing monthly Healthy Chat presentations that we have scheduled. Also, we're doing them by request for community organizations as well. We're going to have quarterly meetings for our partners, CACs and brokers, giving them updates, giving them materials that they can share, and also making sure that they know where to get the information that they may need while they're out in the field. An important add here is hosting year-round enrollment fairs. And typically enrollment fairs are only done during the open enrollment period, right? Those are our pop-up events that we do, and we see consumers and enroll them on site. So the plan is to extend this to help consumers specifically in underserved areas of the state and those targeted cities that we spoke about previously, and providing that extra help in person all year round. So we know individuals feel more comfortable doing this process. Some individuals feel more comfortable doing this process in person, and we wanted to provide that opportunity. And it's also important to note that the enrollment fairs will be in addition to the in-person help that consumers can get through our navigators, certified application counselors, and brokers throughout the state. Also, for this year, we're launching year 2 of the Broker Academy. So consumers in underserved areas will also have more access to the in-person help that they would need to get through the redetermination process. So the key takeaway here is we're working with community organizations and partners at a deeper level, right? Having more consistent meetings, sharing updated information and materials, possibly having enrollment staff and brokers on site for certain community organizations, pending budget and available staff, of course. But most importantly, we're working really hard to educate consumers so they're more comfortable getting through the process and making them aware that there are multiple ways that they can get the help that they need to go through this. So, of course, this effort can't be done by one organization. So hopefully the takeaway here is that there's multiple efforts happening at different levels with different organizations. And I'll pause here for any questions.
Mr. Chairman, very quickly, I know we're running out of time. Just want to augment what Tammy was indicating. That obviously, this is going to require a lot of resources. But Tammy indicated in person, because some of this population, they need the in-person help. Otherwise, they'll go without health insurance. So, so we plan is to hire additional enrollment specialists on a temporary basis, and place them at the heaviest areas, where the targeted areas where we have the highest number of folks. And again, although a smaller slice of the 430,000, but we don't want anyone to go without health insurance, especially those who are who have a chronic illness on a maintenance drug. We don't want them to find out when they go to the pharmacy or when they go to the doctor that they don't have insurance. So we're going to do everything we can to make sure, minimize the gap in coverage for that population. And that will require us to be in person in those communities. So we will hire on a temporary basis on specialists to place them, and some of our partners to provide that additional resource to help people get enrolled, and having the broker graduates from the first year, and having some of them in some of those communities, organizations as well, would be very helpful as well.
Appreciate all of this. First of all, this is a very important topic right now, so I don't feel bad that we've taken the additional time to talk about it. We do have a couple of our directors, a number of them, I think, who have a hard stop at 10:30. So James, you prioritize for a second.
No, yeah, we'll do this broker account very quickly, about 5 minutes. Then Susan could cover at the next meeting updates, or we could send a note to the board about the legal updates about the ACA in writing.
That would be, let's do that. And
Okay.
And before we pivot away from this topic, just make sure we don't have any lingering questions. And then let's move to the Broker Academy quickly. Thank you.
Okay, I'll get through this quickly. So things are moving along quite nicely for the Broker Academy Year 2 launch. I feel like Year 1 went by so quickly. So the new webpage is up with the new program and the details. We're gaining a lot of visitors. We've had over 1,400 visitors to the page last month, compared to 391 in December. And that's still an impressive number because we weren't promoting the program in December. So that was great. We're seeing more male visitors to the site, which in comparison, a majority of our first class identified as female. So it was interesting to see the makeup of the visitors to the website. And the age range for all of the visitors are pretty equal across the board, which is great too. So we're seeing visitors from all over the state. Top cities include Hartford, Bridgeport, and Waterbury areas, which are areas that are, higher uninsured, and we're happy to continue the momentum in those locations. So our recruitment efforts are ramping up. The outreach team has been attending fairs, doing presentations for community partners and state agencies as we did in Year 1. I won't go into all of the activities, but really, I think over the past few weeks, we've connected with over 80 community organizations to promote the Academy and share information. Most recently, we actually had the Department of Education agree to share this program information with all the adult education directors. So the program is gaining a lot of traction. A lot of people are already aware of the program, so they're ready and willing to support. And we'll continue this recruitment process with our bi-weekly info sessions, which are still going on. Last call, we had over 40 attendees who were interested in applying. and wanted to learn more. We also had some brokers that joined that call as well. They wanted to learn about the program and how they can get involved as mentors. So just to recap, we're looking to recruit 100 students. We're going to do 2 classes this year in Hartford and New Haven. Applications are set to open at the end of the month, February 27th. And the plan is once the students are accepted, we'll be hosting weekly meetings as we did for them last year to get them ready for the in-person class. And so this was especially helpful for a lot of the students. A lot of them haven't been to school in years, so that worked out very good for them. So everything's going smoothly, and we're looking forward to opening the application up in about a week. And that's all I had for updates. Thank you.
Matthew Bachman has a question or comment.
It's a real quick non-programmatic question, but the gender breakdown that you mentioned, do we require gender, and as a folks to tell us their gender, and do we offer a non-binary gender option?
Yes, by state law so this is those gender questions that will be on the application is completely optional, just like in any other HR case. But it's just interesting to see the breakdown because we know majority of brokers currently in Connecticut are male. In our first class, we're primarily minority female. So that's why I mentioned the gender breakdown here, but not a required question.
All right. Yeah, I agree from the interestingness of we're giving more folks opportunities to step into this space where they can sort of have an economic good and also potentially connect with a different population. But it just, obviously want to make sure that we're also sensitive to the needs of the broader population. That's all. Thank you.
Absolutely. No problem.
Thank you. Thank you for that update. Very, very good. I think maybe we'll call it, James, if you're okay. Poor Susan.
Absolutely.
We cut her off every time. I feel bad, but we're going to do it again. I'll give you one last word, and then we'll call for an adjournment.
No, I appreciate the board's continued input. And again, we went through a lot in preparation for the Medicaid unwinding. So if anyone has any suggestions or thoughts, or if we're missing anything at all, please reach out to me. Let me know. Happy to take in your input and move forward. But again, it's been 12 months of work between us, DSS, and OHS. We think we have a good plan, but there may be gaps in there that we're not aware of because we've been dealing with it for 12 months. So the board seeing it for the very first time could be much more objective than we can. So if anything glaring jumps out at you, please let us know so we could make the necessary adjustments. And we will keep the board and updated as we move forward. And even when we're at meetings, we'll send out a note to the board so that they know where we are and what we're doing to keep the ball moving forward. Thank you, Mr. Chairman.
Thanks, James. A very good engaged conversation, great information for us. So we thank you very much for all of that. Thanks to the team. If I could, then could I ask for a motion to adjourn the meeting?
So moved by Ted.
Thanks, Ted. Second?
Second, Tom
Paul,
McNeil.
second.
Thank you very much. Let Martin sort that out. Charlie Klippel, yes.
Paul Philpott,
Yes.
Claudio Gualtieri,
Yes.
Deidre Gifford,
Yes.
Grant Ritter,
Yes.
Steven Hernandez.
Yes, thank you. Very informative meeting.
Thank you. Andrea Barton Reeves, Theodore Doolittle,
Yes.
CC Woods,
Yes.
Thomas McNeil,
Yes.
and Matthew Brackman.
Yes.
Thank you.
Thank you all very much. Bye-bye now.
Thank you.
Bye-bye.